All right, good morning. Good to see you right here on Wellness Wednesday. The show is your world. How are you doing? It's very cold right here in Nairobi, so I hope you're keeping safe and warm. Welcome to the show. My name is Winnie Lubembe, and I'm really looking forward to this conversation today because we have talked about it for a very long time, okay? But still, there's something that either we miss or we maybe do not understand because of the so many myths and misconceptions that are out there, or sometimes maybe we are scared to ask the serious questions that we need to be asking. I am talking about uterine fibroids, and today we really want to delve deeper into understanding uterine fibroids. What is it that we miss, okay, and what is it that we need to really be cautious about? But also we'll be looking at a treatment or a procedure that is being used that is considered somehow, I want to say somehow safe, but we'll look into it as we continue with the conversation, and that is on uterine fibroid embolization. So stay tuned until the end of the show because also July is Fibroids Awareness Month, and it's a good thing that we're starting this conversation on the first day of July. So happy new month to you as well. So my guests are already here, and before I introduce them, let's just see what we are asking you this morning. As per usual, we always say the question is very simple, but really the question is very simple, okay? And the question that we're asking you this morning is, if your body could send you one message today, what do you think it would say? Okay, and remember, our bodies are always talking. It's always telling us something, okay? So if your body could send you one message today, what do you think it would say is a question that we're asking you right here on Your World. So feel free to engage with us on our social media platforms as well as on our WhatsApp number, which are open, okay, and send in your views or even your questions really as far as uterine fibroids are concerned. But my guests, like I said, are already here, so I'm just going to start on my farthest right. And we have Dr. Charles Muriuki, who is an obstetrician, gynecologist, also advanced minimally invasive surgeon, an endometriosis and reproductive health specialist from Third Park Hospital. Good to see you. Thank you so much for making the time to join us this morning. We also have Rhoda Wanjiru Kibunja, who is here to talk to us about her journey as far as fibroids are concerned, but also the treatment, and that is on uterine fibroid embolization. Good to see you. Thank you so much for making the time.
Thank you also for having me here.
To also just allow yourself to speak to us on the uterine fibroids. We really appreciate that. And we also have Dr. Naushad Karim, who is an interventional radiologist from Aga Khan University Hospital. Good to see you.
Thank you.
Thank you for making the time as well. Dr. Charles, can we just begin with you? Because like I said, we have talked about fibroids for a very long time. And even here on the show, on Your World, we've had numerous conversations on fibroids. So what is it that we're not saying as far as fibroids are concerned?
Yeah, maybe there's actually too much talk about it and it scares people. But yeah, fibroids are non-cancerous growths.
Yeah.
And it's basically muscle inside the uterus or outside of the uterus or inside the cavity of the uterus that tend to cause symptoms.
Yeah.
So arguably, if you walk around town and take maybe 5 women and conduct a scan on them, you might find that maybe 2 to 3 have fibroids.
Yeah.
The question usually is, who is having symptoms of fibroids and who needs treatment?
Okay.
Such that we don't create a scenario where somebody does an ultrasound and it's told that you have fibroids, and that becomes a downhill in terms of, oh my God, does that mean I won't get children and things like that? No. It's simply saying, are fibroids causing symptoms or not? So the ones that cause symptoms are the ones that we treat.
Okay.
And I think we're here to talk about the different
treatment options that are there. And even when we're talking about those who have symptoms and those who do not have symptoms, which one are you seeing more? Are you seeing patients presenting symptoms, or are you seeing more patients with no symptoms at all? Actually,
more patients do not have symptoms. But because a scan was done and they were told there's a fibroid, it actually can take them down a rabbit hole.
Yeah.
So I think more often my work is usually tell them, look, yeah, we've seen a fibroid. Yeah, it's not causing any issues. You're probably okay until you had a scan. If you had not had a scan, your life would have continued pretty much okay. Yeah. So the question is, who's having the symptoms? And the symptoms that we usually would want to check out is, heavy menstrual flow. Yeah. And sometimes there could be coexisting issues that cause pain, but fibroids generally do not cause pain. But you could have fibroids that also lie on the bladder and make somebody feel like they need to pee a bit more frequent than normal. Or sometimes they may, lie on the rectum and cause some bit of constipation.
Okay.
So it's either those symptoms of pressure or heavy flow. And heavy flow causes, anemia, and that becomes a concern.
Yeah. And you see, majority of the times when you look at the symptoms, they mimic so many other things. So it's easy for people to think, oh, well, maybe I drank too much water, or maybe I didn't do this, or maybe I didn't do that. Fibroids might not be the first thing that comes to mind when we're talking about this symptoms. And we'll come back to you to unpack more on the same in terms of when they when should they be a concern? And at what point then do you go to a hospital? Because Dr. Karim, I do not want to believe that you always see people who are just like, me, I'm just here to come do a scan, see what is happening with me. There's always something that brings people to the hospital, people, right? Yeah. So can we talk about what are those things that usually drive people to see you and then maybe in turn find out, oh, there's actually something else going on. Yeah.
So mainly it's the symptoms. So women, a lot of times the women we get who come in suffering from a heavy bleeding, and it basically makes them miss their work every month. It makes them very weak, lethargic, because their hemoglobin, the blood levels fall, and they really suffer a lot. So those are the commonest symptoms that women present with to us. Then, like Dr. Charles said, that we also get women who have symptoms related to where the fibroids are lying. So if they're pressing on the bladder or pressing on the rectum, then they're constantly having to wake up at night to pee, or constantly constipated, bloated. We also get those women as well.
And we'll also come back to understand. So then, because again, there's some symptoms that Dr. mentioned, but also for those ones who don't have symptoms at all, right? What are some of these other things that bring them to the hospital, and then you're like, oh, so there's no symptom at all, but then this is what we're seeing from the scans that we're doing. But Rhoda, speaking to you, because fibroids is one of those conversations we talk about as women almost on a daily basis, or either we know someone or we have an experience with the same. So prior to your diagnosis, can we just talk about life for you? What was it like? Were you aware about fibroids? Did you probably know someone who had fibroids that you're like, okay, maybe I need to go and get checked, or probably you went to a hospital for a different thing?
Frankly, I before my diagnosis, I really wouldn't say I had heard about fibroids.
Okay.
But I didn't know anyone per se talking about it.
Okay.
And then, so even for a long time, when I started having the symptoms, it was not being brought out clearly that I have fibroids.
Okay.
Yeah. So we would treat many things. And it took actually having an experience that now really shook me. And then I think at one point I was like, I'm not getting the answers from my gyno at the time. And I think at that time I called my mom because I was panicking. And then she pointed out, have you ever been diagnosed with fibroids? And I think that's when it hit me. It could be fibroids.
Could be,
because I had been going through school. I think at that time I was going through what we call part-time studies. And there were days, yes, when I have my menses, I'd rather stay away from school, from going to university to avoid the embarrassment. Because I just couldn't understand why I had an overflow. It didn't matter what size of pad I used. Could even use double protection, and it just didn't seem to be curbing the situation. So I'd prefer to just, on those days, I stay home, and then when that period is done, I resume.
And can we go back? So the heavy menses, is it something that you have experienced ever since you started your periods, or at some point did it come about?
No, I wouldn't say I had an experience with heavy menses when that started, I guess during puberty. that was not my experience. It just, I already had my 2 kids.
Okay.
By the time I started experiencing the heavy menses, and then it even escalated now to also very severe cramps. Yeah, which was never my problem before. I could get cramps, but they were not severe. And so in trying to solve that, in fact, now the other worry was I also had a drop in my, I got anemic. I had a drop in my hemoglobin, and we are trying now to figure out what these issues are. And I don't know why we didn't think fibroids until, for me, it was more like an emergency. Yeah.
I see. And you also talked about, you treated so many different things. Fibroids was not one of those things that was like, oh, maybe it could be. So can we talk about those many different things that were being treated?
Okay. Okay, so initially I had an experience with a cyst.
Okay.
So we thought it was just the a cyst problem.
Yeah.
And then when it came to the cramping and then the heavy menses, sometimes I actually used to attribute it to I must have very high iron. Okay. So my body is just dispelling.
Right? It's like I have excess of it.
Yeah. And then again, it would be when I had my 2 children, I had also put in an IUD. So again, we thought it was just hormonal. Yeah.
Okay.
So the hormones are just wreaking havoc in my body. So we just couldn't pin what exactly was just causing until it was, like I said, to the very end when I actually was now bleeding internally. And then it was not actually displaying itself.
Okay.
But I could feel there was something wrong. And I think now one fine morning when I woke up and I stood up, it just all gushed out. And now there was this panic and I'm like,
what's happening?
Yeah. So I quickly rushed to the hospital. And that's when we did the ultrasound, and it became clear that I had fibroids.
What size were they? Would you remember?
I just remember there were multiple.
Okay.
And they were, they're always of varied sizes.
Yes. Yeah.
I think the big one being about 6 centimeters. So for me to manage the bleeding, it was more or less I get diagnosed with the fibroids, and I think 2 days from there I was already in surgery trying to get rid of the fibroids.
And thanks for that, Rhoda, because Dr. Charles, I'm trying to imagine, is this a common thing that you probably see or experience, especially when it comes to the symptoms or the presentation of fibroids for different people, where you treat so many other things and then fibroids is like, oh, okay, hi, I am here, it's actually me, it's not all this many things that you're trying to treat?
Yeah, the symptoms can overlap for different conditions.
Yeah.
And I think that's why we encourage we encourage patients to seek healthcare.
Yeah.
And actually have an assessment done to correctly diagnose it. Because I feel sorry for Rhoda, the fact that she went through all that. I mean, by the time you're bleeding out, I mean, that means we probably should have picked this a long time ago.
Yeah.
It's always good to confirm, even if you think that, maybe it's not this particular condition, because an ultrasound is really, it's not as expensive, and it's not an invasive procedure per se.
Yeah.
And it's more accessible nowadays than before. We should be able to do an ultrasound and actually see if there are fibroids or not.
Yeah.
Because by the time somebody gets anemic, that means you're almost now dealing with the complication of the fibroids, which is a low blood level. And we don't want to get that.
Yeah.
that level. Yeah.
Yeah. Are the presentations different for different people? Because again, like I said earlier on, we talk about fibroids and we just say, yeah, you know, I know someone, maybe my mother, my friends, you know, and based on the classic symptoms that are listed, even when you Google, so most of us would tend to focus on those ones that have been listed. And if you don't present maybe with one or two or three, you're like, oh, maybe I'm okay. I do not have this. So are they different for different people and then
Yes.
present at different stages probably?
Yes.
Like, yeah.
And when you just said that, I remember there's a patient who came and told me, like, I've been working out in the gym and I've been trying to lose this belly fat and it's not going anywhere.
It's not going away, yeah.
When I examined, I told her, look, I think you have fibroids. You know, it's not the thought, it's not what you would think about.
Yeah.
But no, when we talked about it, and you know, she later did say that, yeah, you know, now because of the size, because for it to be obvious, like a pot, and she's trying to lose it, it's significant in size. The uterus is significant in size, meaning there may be more than one fibroid, maybe multiple. And I had to ask her to probe her father and ask her, do you have to wake up at night to go pee? And she says, yeah. By the way,
But I think it's common.
yeah, I
It's
thought
like,
it's
yes,
not
the
because
glass
I
of water
take
before you
what
go
I
to
said.
bed.
No, how many glasses of water do you take? Do you take tea or coffee in the evening? So this now is affecting the quality of her sleep and invariably affecting the quality of her life. So now, sometimes the symptoms are not overt. It's up to the doctor to say, let me probe further. You know, okay, and then there is the classical symptoms of heavy bleeding during the menses, and this usually tends to be, you know, caused by the fibroids that are inside the cavity more often than not. This one might actually not be showing on the outside or inside the muscle. You can't feel it from above, but it's inside the cavity. And those ones tend to cause a heavy flow. They could also potentially, you know, increase the risk of a miscarriage, because that might be the reason why a woman has come. And then when you do a scan, you see a huge fibroid and it's in the cavity where supposedly the baby or should be growing. So that potentially can affect. It's not been shown by research to completely you know, demonstrate that it does affect, but it can. And it's not to say that removing fibroids improves fertility, by the way. It's just that sometimes there might be an association. But generally, it's the heavy flow that should point you towards fibroids. I know there's another sister condition called adenomyosis that can cause a bit of pain and heavy flow, especially with backache. But an ultrasound should be able to differentiate between the two. Yes.
I see. And Dr. Karim, to bring you in, because Rhoda talked about treating very many different things, you know, but eventually she got the correct diagnosis. So why is it so easy to miss fibroids, or why is it difficult to properly or diagnose fibroids on the first instance?
Yeah, I think because there are many overlapping conditions that can present with the same symptoms. So that's why I think it can be missed, but that's why getting or seeking healthcare early if you get the symptoms and undergoing the appropriate scans is very important to get the diagnosis.
But what about those ones with no symptoms? What exactly does diagnosis then look like for them? Because there's nothing. You talked about, you know, one of your patients were like, I'm working out, but this thing is not going away. So it's not like a classic symptom of what we're used to when you think about fibroids. So for such a person, what does diagnosis then look like for them?
So we do see quite a lot of such cases where patients may be undergoing scans as part of a wellness check, and then they're seen to have fibroids, or they're having scans for something else which is not related to the fibroids or to the pelvic symptoms, but the pelvis gets scanned as part of their care, and fibroids are seen. So for us, we always say that we only treat the symptoms. So we don't treat the fibroids, but we'll treat the fibroids if they're symptomatic. If they're not symptomatic, then there's no justification to intervene.
Yeah. Interesting. And we'll come to you, Dr. Charles, then to pick up from that. But Rhoda, so you finally got your diagnosis. You know exactly what you're dealing with. What was that moment like? Was it relief? Was it, Okay, so now what do I do? Because like you said previously, you did not know someone with fibroids or probably like talked much about the same. Yeah.
Well, to start with, there was a lot of disappointment because I was counting all the visits to the doctor and how we missed this obvious,
Yeah.
this obvious diagnosis, and then there was, I think also there was the frustration of now trying to solve a problem now, because now you're more reactive rather than trying to have managed the situation with time. And then there was also the aspect of fear, because then the alternative at the time was surgery or you stay with the fibroids. And I'd already gone through one surgery to remove a cyst, and then I had my second born was through a cesarean. Yeah. And the idea of me going through surgery again was just frightening. So I think the first thing that crossed my mind is I wanted a simpler alternative to surgery. But at the time, and Mark, we're talking about my first diagnosis of fibroids. I opted initially for what we call laparoscopic. Yeah. And either they were too many, and I remember I think we didn't capture everything. So I think actually 6 months after the initial surgery, I was back again to remove another fibroid that might have been overlooked. And the reason it presented itself is this time it was maybe Dr. you would know, it was prolapse. It was prolapsing. Yeah. So you can imagine after my initial diagnosis is I had to go through surgery twice. It was not, it was minimally invasive compared to the incision, but still, that road to recovery is also tedious. To me, I considered there were many life-threatening as issues that presented themselves with going under the knife. Yeah. And then after the second surgery, I was told I needed to put in a hormonal IUD to avoid recurrence of the fibroids. But unfortunately, that option didn't last very long because I think 6 years after the surgery, I now had the same symptoms again, recurring. Yeah. But now because of my previous experience, I knew it was a fibroid. Yeah. It had already been diagnosed. So I go back again to the doctor and I'm like, surgery is not an option.
Give me something else.
Give me something else. Throw back the IUD. It's like it's too late for the IUD. It's like trying to, it's like trying to put a Band-Aid on something that is on a broken leg,
Beyond, Yeah.
So it's like it's too late for that. And then now, obviously, they look at your age, and then there's now that idea of, for it to not recur, do you consider now what they call a hysterectomy? And I was like, no, let me think about it.
Yeah. And Doc, can we just unpack that? Because it's a lot. First of all, fine, you get your diagnosis, but then again, on this other end, there's like, okay, so then what is my life going to be like with this new information, this new reality that there's fibroids? And now on top of that, you have to think about management, you have to think about all the treatment options, and then you've been through it. It can be a lot on one person. So can we just unpack that in itself? And then something else that's interesting, because majority of the times we're told, when you get pregnant, your cramps, they will disappear. If anything, women are being advised, get pregnant, with the same. So can we unpack those two?
Yeah, that's quite a bit. But Rhoda, I'm so sorry that you went through so much. I think generally speaking, we almost sometimes ignore quality of life. When I always ask if the periods, whether it's pain or flow, makes you have to rearrange your schedule. You have to cancel an appointment. If it's a work appointment, you cannot travel. That is affecting the quality of life. And that's where we have to start from, so that we don't make it sound like I've learned how to manage or cope with it. You know, so I think here there are several things that come out. I think it's important to always know there are fibroids that do not cause symptoms. Those are asymptomatic fibroids.
Yeah.
We don't bother with them. I always insist we treat a patient, we don't treat an ultrasound scan. So that you don't go shooting, you know, every fibroid because it's been seen.
Yeah.
Okay. And number two, if you decide to treat, what options are there? And what would be the most important factor? The most important factor and the question that you have to ask a woman is what their desire for fertility would be. Because if somebody is 20 years old with fibroids, it's different from a 45-year-old with fibroids.
Sure.
Okay. So if fertility is desired, then you'd want to go for options that do not compromise fertility.
Yeah.
And also asking, are there other, coexisting conditions? You know, for instance, if somebody has diabetes, or maybe has had a history of a blood clot, all those are risk factors if you think about surgery.
Yeah.
So you want to tailor the treatment based on the patient's symptoms, what their risk factors are, but more importantly also what the patient's wishes are. If somebody says, I do not want surgery, is there another alternative? Yes, there is another alternative, and we should be able to offer all these options. If it's a keyhole surgery that is being offered, we should know where the fibroids are, because with keyhole surgery, you may not be able to have the tactile feel like open surgery where the fibroids are. So you almost like have to have a 3D map in your mind, either from a good ultrasound or an MRI, to know where exactly the fibroids, we call it fibroid mapping, so that when you're doing the surgery, you know where you're going to go and get it out. But generally, laparoscopy is not recommended for somebody who has, multiple fibroids, not unless you are able you have the skill set to be able to remove all of them laparoscopically. Because of course there is advantage of minimal access surgery in removing the fibroids. So sometimes open surgery is the only other alternative if somebody has multiple fibroids and if they are still desirous of fertility. If they're not desirous of fertility, then you can give a bit more options. Okay, and there's medical treatment, but if medical treatment doesn't work, then you need to think about ways to reduce those symptoms. So surgery being one of them, either to remove the fibroids or to remove the uterus. And that's either through keyhole surgery or open. Or now in this case, we're discussing about fibroid embolization or minimally invasive options where you're blocking off the blood supply to the uterus and to the fibroids to reduce the symptoms and help the fibroids shrink. And there are also other newer modalities like HIF, where is focused ultrasound energy on the fibroids to make them stop growing. And why should we be talking more about this? Because African women are more predisposed to fibroids than Caucasian women. And we see them having bigger fibroids and more symptoms compared to Caucasians. So it's important for us to have that conversation.
Yeah,
Yes.
and not just focus on what is being done in the Western world, for example, because
Exactly.
again, the conditions are pretty much different.
They're pretty much different.
From where we are at. And Dr. Karima, we're told, fibroids mostly presents among women between the ages of 30 and 50. But what are you seeing from, say, your day-to-day interactions with the patients? What is it that you're seeing? Is there a trend that maybe you're a bit concerned about? Are there things that you're noticing that are different so that women should really not just think, oh, I am 30, now I need to, think about all these other things, fibroids being one of them?
So from the scans that we see, we do see women even below the age of 30, so even women in their 20s do have fibroids.
Okay.
Of course, with increasing age, the risk of developing fibroids also increases. The other thing is one of the risk factors for fibroids, or one of the things that can predispose you to developing fibroids is not having children at an early age. So, so with the modern lifestyle where women are getting married at a later age, conceiving at a later age, the probability of developing fibroids is increasing as well.
Okay. What's the youngest that you've seen?
I think the youngest I've seen was probably around 25.
25.
Yeah, who had fibroids, yeah.
Oh, okay.
Yeah.
And Doc will come to you then to say what exactly does this say in terms of either our lifestyle and just even our health-seeking behavior, really, as people in general. But Rhonda, you talked about life-threatening moments, and especially during the whole period of understanding. Okay, so which is the best option? For me, because again, like you said, you had gone through surgery at some point, and you're like, that is not an option for me anymore. Can we just talk about that moment and those experiences as well?
So I tried to hold it off for quite a while.
Okay.
And I think every time I would revisit the discussion, they had either grown bigger and the symptoms are worse. I think when Dr. you mentioned even travel, I think one experience for me is I was traveling long distance and everything was fine along the travel. It was like a 10-hour road trip, and when I got to my destination, I just stood up and someone is asking me, something leaking from your bag? And I'm like, leaking? And then when I look down, I discover I'm the source. And it was very embarrassing, I must say. In fact, and then so I was like, okay, Rhoda, now you need to take this seriously. You need to look for a solution before it gets worse. And also the nature of my work required me to sometimes sit in certain places for long periods of time. So the position was, now I need to get it fixed. But every time I would revisit the topic, we'd be back to surgery. And now, in fact, what was being pushed mostly was the hysterectomy, so that I get over and done with that problem. Because once you're done with your uterus, you don't have to worry about fibroids anymore. Yeah. So I think for me now, then I think at the time there was also this now open discussion. I would say things also have been different, because initially, I think when my first experience was there, people didn't openly talk about fibroids. There was no sensitization. And by the time I was revisiting that topic last year, 2025, we all even had celebrities like Lupita talking about her experience. And I did my research, and I could see there was the UFE, now the uterine fibroid embolization. But I was like, no one has thrown me that idea in among the many list of solutions. So I was in my mind, I thought it's only done overseas. It's just available for people in the developed world, and it's not available here. So then I had to be purposeful with my Google searches. I was looking for UFE in Kenya, and I think that's when I ran into Dr. Noshad.
And it can be a lot, because again, you're trying to find a solution to this, and there's so many other things that is being presented to you that you're not comfortable at that point to consider that, because you have been through that journey. It can be a difficult moment, because one, you want to get help, you want to finally find ways to treat this and move on with your life. But then again, there's so many other things to consider. How are you at that point, mentally, physically, spiritually, like all aspects of what makes you you?
Okay, to be honest, I think the main thing that was running my life at that time was fear, because that was what was pushing. But then now, you choose to take control over your life, and you're like, okay, if this is not being presented to me, or if I'm being told this is the only alternative, which is the hysterectomy, I was at that point where I need to take charge and find out. In fact, I remember when I first talked about UFE, finally, because I had to see a gyna in Aga Khan who could then rule out that UFE was the way to go. He was like, you look like you have done your research. I told him I have viewed all the videos I can possibly.
Extensive years of research.
Yes, I have done the YouTube videos. I have done everything I need to I got there saying, I think UFE is the next alternative for me, other than the hysterectomy. Yeah.
Yeah.
And yes, I was happy I took charge, and because then, like I said, and that's the experience sometimes I find also with now when I have these open discussions about my experience.
Yeah.
That option is not being discussed enough to women who are suffering the symptoms.
Fibroids.
Yeah.
Do we know why? Is it that maybe it's not very well understood? Are there maybe like risks? And I know we'll talk about it more during the second hour, and just really to focus on what is it, where is it done, how is it done, and all those things. But just to pick up on something that you said in terms of patient advocacy and someone advocating for themselves and saying, fine, I understand all this list of treatment options that you're giving me, but this is what I feel is best for me. What is that space like? Because a lot of patients would trust what the doctor says. If the doctor says hysterectomy is the way to go, that is the way to go. Because again, there's fear. The doctor knows best. So can we talk about that space of knowledge, advocacy, and just patients advocating for themselves? And what if whatever they want is not good for them at that point? Yeah.
So I think we do quite often encounter patients who have searched on Google and come to see if they're suitable candidates or not. And who have actually been scheduled to undergo surgery during the week or something, and they're like frantically rushing for options that to avoid surgery. So I think it's because UFE it's increasingly becoming available in the country, but a lot of like gynecologists, when they're undergoing their training, they've probably not been exposed to it as an option in treating symptomatic fibroids, and hence they don't think about it when talking to the patients. So as the number of interventional radiologists increase in the country, and as it becomes more common, hopefully that should change. But also as patient awareness increases, then the patients should also be able to ask the gynecologists if this is a viable option or not.
And Dr. Charles, what are some of those questions that patients should ask? Because like I said, sometimes you're presented with all those options. Amma, you're told this very many big words and big jargons, and at that point you're just like, please tell me what the issue is and how do we move from there. So what are some of these must-ask questions from the patients to at least get a proper understanding of what they're dealing with, what life would look like with this new reality that there's fibroids, and also the treatment options?
Yeah, so I think the first question is, okay, fine, there's an ultrasound that has come out and said there are fibroids. The first question you should ask, are these fibroids causing symptoms or not? Because if they're not causing symptoms, we should probably not, create a flare about it. Because sometimes, there's a lot of, I've seen women take concoctions to help the fibroid shrink, and I'm saying this is not affecting your life. And there isn't any concoction that you'll take that will shrink them. The second question would be, if I need treatment, how does this affect my potential fertility?
Okay.
So if surgery is an option, what type of surgery will it be?
Okay.
And how does that look like in terms of recovery as well? So that I honestly believe at every point I should be able to break down this information in a way that even my own grandmother can repeat it with an understanding of what I've said. And it should be an informed, shared decision-making model.
Okay.
Yeah, because I think we're in an era where, there's information, it's information age. I think it's only fair to have information given to the patient and they are guided. My work as a doctor is to guide them on, these are the symptoms you have, this is where you are in terms of your desire for fertility, this is the options that are available for you in terms of treatment, what do you feel most comfortable with? So that we don't end up doing what the doctor said. But, I wasn't sure. And, that's why you end up having a patient frantically ran to Dr. Noshad for. I mean, I have had a patient, and I told them, I don't think you are a good candidate for surgery.
Yeah.
She says, I want surgery. I said, no, I think you need UFE.
Yeah.
Because I'm looking at your risk profile, and I think you probably would benefit from UFE than surgery.
Yeah.
So I agree with Dr. Noshad that probably in our training we don't have UFE as an option in the public sector. So that means that not many gynecologists are exposed to it.
Yeah.
So that means in your day-to-day practice, then I may not be able to have that at the forefront. It might be something that I read about in terms of research, but I've not seen it practiced. For those who've seen it practiced, I have been able to see it practiced, and also been able, luckily, to do research in UFE as well. It actually opens the opportunities for women for beyond just surgery, because some of them have had 2, 3, 4 surgeries.
Yes.
I mean,
Yeah.
if you think about it, surgery is going to be more risky. To even their recovery is going to be a bit stormy.
Yeah.
So if there's an option that is non-surgical, why not take it?
Why not? Yeah, why not exploit? And Rhoda, I hope I'm not imagining my own things, but you said after going through surgery, those are recurrent and to growth, and it became worse.
So
Yeah.
yeah, so with my first diagnosis, I did not want to go through surgery.
Yeah.
And then we went through now what we call the keyhole surgery. I think the fibroids had not been well mapped out.
Okay.
So I think some were taken out and others were left.
Some were missed.
Yeah.
Yeah.
And then you also have now this long road to recovery after that, because it's still surgery. And then you find out this other option that the keyhole surgery that I opted for, turns out might not have been the best option, because you left out a fibroid that now has decided it wants to exit from the body, whether you like it or not. So it's back to surgery again, to now make sure you get rid of all the fibroids.
Yeah.
So yes, that was my first experience with my first diagnosis.
I see.
And then you brace yourself for the recurrence, because you're warned it'll recur. But you try and manage between the recurrence. You try and manage the best you can.
Yeah.
And that for me was through an IUD, which is hormonal. So you manage, and you just know it's just a matter of time. It's not if, but when.
But when.
Yeah. And when the when happened again, then you now have to revisit the topic of how do I deal with it again? Yeah.
Yeah. And not get yourself in a position where, again, like you said, you sometimes there's the anemia, and then there's also the almost fainting, because again, right, because of anemia. Like you do not want to get yourself in that position where you were before. Yeah. Okay, let's go through a bit of feedback, and then we'll go on a break. And then when we come back, we'd really want to understand. So then, how do you determine who qualifies for what type of treatment, and also what is available in the country in terms of knowledge as well for people? Because like Rhoda said, you're being presented with all these options, and there's also fear. What if I choose this and maybe it ends up, being worse? So we'll unpack more of that. But the question that we're asking you today is, if your body could send you one message today, what do you think it would say? So let's go through your feedback on WhatsApp. But I see one here on Facebook. This is Matthew Brayo, who says, go to the gym. The body will tell them, please go to the gym. Okay, but let's see what you guys have to say on WhatsApp, if we have them ready. Okay, this one says, I was diagnosed with fibroids and given treatment, and by the next scan it had reduced in size, and I am in menopause. So the question that they're asking is it true that it will disappear with time, since I did not receive any more? Okay. And then do we have another one? Another question, I think. All right, so this one says, an observation from radiosonographer. My name is Ontegi Momanyi, a radiosonographer at Kairat Medical Center, I think, and says, during my work in ultrasound imaging, I have observed what appears to be an increasing number of young women presenting with uterine fibroids. Recently, I have performed 17 pelvic ultrasound examinations on women aged 20 to 26 years, with most patients being 23 years old. Many of these women were diagnosed with fibroids only after the masses had grown to 7 centimeters or larger. Although this is an observation from my daily practice and not a formal research study, it raises concerns about the possibility of delayed diagnosis among young women. Many patients seek medical attention only after experiencing significant symptoms, by which time the fibroids have already become large. I believe there is a need for greater public awareness about uterine fibroids, including education on common symptoms such as heavy menstrual bleeding, pelvic pain, abdominal swelling, and infertility. Encouraging women to seek early medical evaluation when symptoms arise could lead to earlier diagnosis and better treatment outcome. I hope this observation encourages further research and strengthens community awareness initiatives on women's reproductive health. And, signs out on Tegi Momanyi, radiosonographer, Kairat Medical Center, and this is in Kilifi. That's interesting. I'm curious to also hear from you based on that observation, as well as Dr. Charles as well. But let's take a break, and then when we come back, there's so much to unpack, and especially when we're looking at uterine fibroids embolization. Okay, I know there's so many questions still with the same, so engage with us. But if you have a question as well, feel free to send it our way. We'll send it to our panelist for the answers. But let's take a break. We'll be right back with more right here on Your World. Welcome back to the show. Of course, the conversation still continues, even during the break. But today, right here on Your World, we're focusing on uterine fibroids, which again, like I said when we started the show, this is not the first time we're talking about fibroids right here on the show, or even amongst ourselves, in our WhatsApp groups, in our chamas, even at the dinner table, I want to believe sometimes, and I hope that really happens, so that we demystify a lot of myths and misconceptions surrounding fibroids. And today, we're looking at understanding treatment options from surgery to uterine fibroid embolization. And the question that we're asking you this morning is, if your body could send you a message, what would it be? Very interesting feedback that I'm seeing here on Facebook. If your body could send you one message today, what do you think it would say? Okay, so this one says, this is Nyamboro Min GA, says, you need a break. The body will tell them, please, you need a break, okay? And then Nyambura Njuguna says, thank you for carrying me through the cancer diagnosis and treatment. Oh, wow. Okay. Dante says, stop overthinking. The body will tell them, relax. Stop overthinking. And then Mwangi Jordan Asema, the body will tell them, you're misusing me, my brother. So, okay. And then Yobra still Anasema, I need a break. Abraham still says, I need a break. So, interesting conversation. Okay, it's okay, very interesting. Okay. Tony anasema nothing, because I am my body and it cannot send me a message without me. So you are the messenger. But fine, without you, what then would you tell yourself, or what message would you send your body? Keep sending your views and your concerns as well, as far as uterine fibroids is concerned. And like I said, today we'll focus on a very specific form of treatment, and that is on uterine fibroid embolization. But before that, there was an interesting interesting finding. Okay, it said it is not officially research or study, but it's very interesting. Yeah, I'm curious to hear your comments on the same.
Yeah, it's a very interesting observation, and it's I think it's something that we've or I personally have also seen that because we do look at the scans, and we do see young women with fibroids. They may not be symptomatic because at that time the fibroids are small, but those fibroids will grow and become symptomatic. So it is an interesting observation, and I think it's something that definitely it's an area to research into. To really explore this. And Dr. Charles, we were also talking about during the break this fear, and especially amongst so many women and even men in general, really, as far as health is concerned. And majority of us would say we'll only go to the hospital when it hurts. So can we talk about that fear, especially for women when we're looking at fibroids? Because it's not just
the fibroid. It's what will life look like. There's also the fear of, infertility and some of those things that we have been told, say, for example, heavy bleeding or cramping is like, you're not the first one to go through it. Even our grandmothers went through it. So there's some things that we have considered normal, and there's some things that we're scared to even think about or even explore, because what if I go to a hospital and Dr. Charles tells me that I have fibroids and it's not just one, it's like 7 centimeters, right? Can we just address that? And how do we overcome that fear and just go to a hospital?
Yeah, so I think first and foremost, for any disease condition, normalization actually makes the diagnosis get delayed. And that's especially for endometriosis. We say, normalization of pain, of menstrual pain is what makes the delay. Of course, there's, the other risk factors we talked about. It doesn't mean that everyone who, for instance, let's say there's a family history of breast cancer. We encourage women who have that family history to start screening earlier.
Early,
we actually should also highlight that, yes, fibroids, there is also a genetic component to it. And as you highlighted, that, if your mother told you that, then there's that propensity that there could be, somebody in your family who also has fibroids. So the genetics is also important for us to factor in any disease. If there's a family history of diabetes, then it should also tell you should probably start thinking about screening. So I think the onus is on us to say, based on my history, I think it's important to probably get checked. Some diseases, like now cervical cancer, we encourage cervical cancer screening, because we know that is like one of the cancers you can actually treat and prevent using vaccination. So that is important for us to say, you know what, if I have time to take my car for service and I block off because the car has told me at this point in time, after 5,000, 10,000 kilometers, stop, go for service. Please, even you get a point and say, I need to stop and take myself for service. And sometimes I say for myself, my birthday gift is usually I need to have a health checkup. I agree sometimes we might have, screening and we need to have conversations with a doctor rather than, a one-sided scare. Where you're told, oh my God, what have you been doing? Why have you been sleeping on this disease? And, I think that also can scare somebody to say, whatever it is that I have heard my friend being told, I do not want to hear. So it's also just being able to have somebody break down this information in a way that now helps you know how can I do more of prevention rather than having a situation where we're just treating. And that's really why our healthcare system is stretched, because we always focus on treatment. We never focus on prevention.
Yes. I see that. And even during the break, we were also talking about the prolapse. As far as, can we just unpack that? What are the conditions that might bring about, prolapse, and how risky or complicated can it be? And do all people experience that? Because I've never heard of it, and rather thank you really for bringing it out.
I think on that diagram right there, there's something written, pedunculated submucosal fibroid.
Yes.
Okay? So this is a fibroid inside the cavity that is causing heavy flow. But sometimes with intense cramping, it can be pushed out like a baby. And it comes out through the cervix. It's not common, but the problem usually is it tends to cause very heavy flow. And sometimes an abnormal and heavy discharge as well. Unfortunately, that tends to be the most symptomatic fibroid, in the sense that's the one that's causing a lot of heavy flow. That one, by all means, needs to be removed. And sometimes we might even debate with, Noshad and say, should we have this removed before fibroid embolization? Because then it can now affect the outcome of embolization. But generally, a prolapse of a fibroid is basically a fibroid that's hanging inside the cavity that comes out like a baby.
I see that. And also very quickly on the asymptomatic, right? Because again, like we said earlier on, there are some of those classic symptoms where like, yeah, this could point to fibroids. But then again, what about this other group of people who present no symptoms at all? this is me just thinking. So the fact that there are no symptoms, is there a risk of then the fibroids growing, maybe at a rate that by the time they're presenting with the symptoms, it's sometimes almost too late, or making the diagnosis a bit complicated, or even the treatment process as well?
So yes, so if the fibroids are not symptomatic, then we do not treat them, but we can follow up and keep probing the patient, say every 6 months or so, to see if the symptoms are coming, and if they are starting to develop the symptoms, then you can sort of intervene.
Okay. Yeah. All right. So the focus of the conversation today, and that is on embolization, right? So can we just first of all understand what exactly is it? And because again, like we said, there's the criteria. Not everybody might necessarily qualify for the same, or like the candidates for the same. Yeah. Can we just understand what uterine fibroid embolization is all about?
So uterine fibroid embolization is a minimally invasive way of treating symptomatic fibroids. Okay. By minimally invasive, it means that the way we do it is we normally go through the blood vessels and use the blood vessels as like a road network to get to the vessels supplying the uterus and the fibroids. And then we put in some particles to stop the blood supply to the fibroids. Okay. And this, in essence, it kills the fibroids and they shrink. And it relieves the symptoms of bleeding. And as they shrink, the symptoms related to their size also go away. So it's basically it's a minimally invasive method of treating fibroids.
Okay. Yeah. How long ago, or how much of it has been, say, like available in the country, either the information or just the services that are being offered?
So in the country, fibroid embolization started at Aga Khan Hospital in 2009.
2009? Yeah. Okay. Yeah. And now I understand why Rhoda is like, why wasn't I given this as an option in the first month? Yeah. Okay. Yeah. 2009. But how common is it? How much of it do people know as a form of treatment for fibroids?
So it's slowly been growing in the country. So we at Aga Khan we started offering it in 2009. The way we started it is that there used to be someone from the UK who used to come 3 or 4 times a year to do it. Then from 2018 we've been offering it regularly in the institution. We also have other interventional radiologists in the country who offer it as well, who have trained and who are now offering it. So the service is now slowly spreading to other institutions, and it's becoming available in I think all Nairobi, Mombasa, and other parts of the country.
I see that. So Rhoda, you went to the doctor's office with you have evidence of the research that you have done, and you're like, I think this is the best option for me. Okay, can we talk about how you arrived at and I know probably you've mentioned it, before we went on a break, but arriving at that decision and saying, listen, I think this is the best option for me. How did you get to that, and what was that conversation like?
Like I said, first you say no hysterectomy, that is out, and then but you still have the symptoms, so what's the other alternative? Then you do your research. But then I think like Dr. said, every individual has to have their own assessment done and this conversation with their doctor, so that you can tick that. There's some check boxes you need to tick so that you can feel that embolization is for you. For me, I'd already ticked them off for myself, but I just needed the doctor to tell me, Rhoda, I think you're on the right path. So I still needed to have that conversation with the doctor, so that he gives me the green light to proceed. And he looked at various issues. First, as Dr. said, you first now focus on whether you're presenting symptoms. I ticked that checkbox because of the heavy bleeding. there was the I was also having the pressing of the bladder, so there's a frequent urination, and then the concerns of being anemic and all that. So that we checked off, and then we also now checked off, like, are you looking forward to having more children? And I'm like, no. And then, so there are those things we needed to just check off. And then, and also then once that is done, I had already come with the MRIs. So the only thing then he told me is, I think you're ready to go see Dr. Noshad. And he was very efficient, because I think as soon as I was done with the gyne and I called Dr. Noshad, he was like, sure. So if I had them on soft copy, so I just shared them with him, and he took the time to see me. And once I had a conversation with him, in fact, I think at that time I was like, so you can do it in the morning and I'll be out in the evening.
My day.
I just wanted it done in a day, and like a day procedure. But in hindsight, now I know why I needed the one night in the hospital just to manage some situations thereafter. Which to me was far much better, because I've been through surgery, so I was
a day,
one day, one
okay.
night, that's fine. I go home the next day. So I was very ready for UFE, just and then get ready and put that those symptoms behind me.
Okay, and we'll come back to you then to understand. So how is life now? How are you doing now? Like how I see the spark in your face, and even with that question. But Dr. Charles, in terms of understanding, so who qualifies, who doesn't, and all the options that are available as well. Can we go through it?
Yeah. So for fibroid embolization, one of the situations we have to assess well is issues regarding fertility. So if a woman is still desirous of having fertility, then fibroid embolization might not be top of the list, just because we think it could potentially affect the blood supply to the ovary, and that can compromise the capacity of the ovaries to produce eggs, which is important. That is not to say that women who undergo fibroid embolization definitely have their ovaries affected. No. We just know that risk is there, so you want to probably reduce that risk, because you can't quite rejuvenate the ovaries after that. Relative contraindications is maybe, if the fibroid is hanging inside the cavity. Because we know that if you do the embolization, then it can actually, the stalk can fall off, whether it's on the inside or even on the outside. And I'll refer you to that diagram where you see there's a fibroid outside the wall of the uterus.
If you can we have the Kevin, I think probably have the, what is it called, this on the screen, so that people very well. Yes, so we have it for people who are at home can see, but I don't know, Doc, if you can see it from here.
Yes, actually. So it's a fibroid that is probably hanging on the outside wall of the uterus, close to the ovary. And sometimes if they have a very thin stalk, then that might fall off into the abdomen. So it's not to say that you can't have that. We just know that that's one of the conditions that we might need to discuss with the patient that might need a reintervention, maybe laparoscopy to have that. We've had a patient who had fibroid embolization done. We knew that they had a fibroid inside the cavity, and then the following day we had to come and remove that fibroid through a keyhole surgery, from below, what is called hysteroscopy. The advantage was that the embolization had blocked off the blood supply. So she didn't bleed much. But because we thought if we'd left it there, she probably would have a lot of intense cramping pain. So the main issue here is fertility.
Okay, something to really, really consider. I think this is where then the whole patient advocacy, maybe I'm standing for myself and saying, this is what I want. No, there's so many things that you need to really think about.
Maybe also highlight some who actually would be the first line. I mean, the patients who I would definitely consider to have fibroid embolization. So, for instance, somebody who's had a history of a blood clot in the lungs, you know, because surgery increases that risk.
Yeah.
So that's a patient I would want to consider, you know, to have embolization. Remember also the other patients who might have other conditions. Let's say a patient who has leukemia and has fibroids.
Yeah.
You know, you probably might not want to take them to surgery because of the risk of bleeding out, you know, so, but you still need to manage their symptoms. So there are patients who might not be good surgical candidates. The other advantage is if somebody has a low blood level, let's say of 7, 8, you can argue that, you know, it's a very minimal invasive procedure that doesn't bleed much. Because for somebody who's bleeding, for you to, you know, give them blood that's for them to get to 10 before you do surgery, it's going to take a while. Why don't you just consider fibroid embolization that doesn't need that blood level to be at 10? So I think this is just something that we need to educate both the masses and even our own colleagues that it's an option.
On the same. And Rhoda, I just want to hear from you, because again, so you had gone through surgery. Can we look at uterine fibroid embolization through your eyes and through your experience as well? What was that like? Because I know one of the things that you said, just one night in hospital. I mean, it's I can take that, right? But just the entire process, what was it like for you?
So yes. So most importantly, I think, was the MRI that would map out where the fibroids were, and this was done using contrast. Contrast, I think, was to just confirm whether there's blood flowing to those fibroids. I presented those MRIs to Dr. Noshad, and he looked at it, and once he made the decision that yes, UFE will work for you, now it was just now going through preparing for the procedure. Aga Khan, by then I think you were made to see the anesthesiologist way before your procedure, which is good, because then I have seen a lot of people succumb just for some maybe things that were overlooked. I initially felt it was a bother, like, can't you just put me under and finish?
And let's get it done.
But now when you hear a story of someone who just anesthesia is what made them go, then you're like, okay, fine, at least they're taking the steps to be cautious. Because I was going to be under during the process. And then, so those checklists, I think I was not supposed to eat and all that. And he told me it's going to basically take less than an hour. I was equally happy that the only incision was, I kept bragging about, it was just a small dot on my wrist. And but you wake up, and I think there was this, and that's now the reason why he told me maybe you need to spend one night, because you wake up with this cramping pain. So that was pain that really needed to be managed in the course of, and then to just understand the pain levels, because we all have different pain thresholds. I clearly did not know mine when I was saying I want to go home soon after the procedure. I was not aware. So at least I'm glad he told me just spend one night with and so I got released with basically pain medication, and I can say I was home recovering for about 2 weeks. And I'm happy to say all the symptoms were gone.
How long ago was that when the procedure happened?
That's about, it's now 11 months now. It's 11 months ago.
All right. I see that. And yes, we'll come back to now talk about life after and how you're doing right now, and the things that you're able to do now that you really couldn't do before the procedure. But Dr. Karim as well, just understanding the advantages, the risks that are there, and just what really people need to understand. And I know Doc also mentioned some of the criteria and things to consider before saying, okay, Rhoda, you're a candidate or you're not. But yes, the advantages, probably like the pros and cons as far as UFE is concerned. Yeah.
Sure. So I think the biggest pros are that the recovery period is relatively short.
Yeah.
And we do have patients who insist they want to go home the same day. Actually, there's recently we did a fibroid embolization for a colleague from the Department of Radiology, and she was very insistent, I'm not spending a night in the hospital, and she went home. Yeah. So the recovery period is relatively short.
Yeah.
And I think that's the biggest advantage. The other advantages of UFE are that the complications that can happen are relatively minimal. Unlike surgery, where there's especially open surgery, where there's a scar and the propensity of getting infections and pain or bowel injury and all that are avoided. But however, there are risks that can happen, and I think Dr. Charles has pointed out that fertility is something that we do talk to patients about. Newer data is showing that the effects on fertility may not be as bad as was previously thought, but it is still important to counsel patients that there can be an effect on fertility. And the other thing is, if you're looking to get pregnant in the next 1 year, then that's a relative contraindication. Because you need to give the uterus time to recover for at least a year. I see that. All right.
And so those are the pros and cons. I was thinking about it when you were talking, and even when Rhoda mentioned, she's like, there's just like a tiny dot on my wrist. And then this is me thinking, on behalf of the many people who are watching us, this is like the uterus. But the wrist, like, how is that? How is that whole process happening?
So we go through the left wrist, through the artery in the left wrist. So it's just like the way you
just the left. You can't go through the right.
No, so because of the anatomy, we want to try and avoid crossing across the vessels that are supplying the head and neck. So from the left, it's easier to go straight down to the uterus. So just like the way you get an IV line fixed, that's basically how we do it. So and then we use a tiny catheter. It's a tiny tube and a wire, and we go through using X-rays to guide us down to the pelvis. And again, using the X-rays to guide us and contrast, which is basically X-ray dye, we see where the vessels are that are supplying the uterus, and we go into them and then put in the particles to block the blood supply to the fibroids.
That's it?
That's it,
Now I understand why you're like, I need to go home. But are there risks to be associated with the procedure that patients need to be aware of?
Sure. So we always counsel about some of the risks that can happen. So number one is we are going into a blood vessel, so there's a risk of bleeding. At the wrist, it's very easy to control and manage. It's a small artery. Number two is injuring the vessels we're going through. Again, this technology of going through the vessels has been around for many, many years. It's what cardiologists also use to treat heart attacks. So the equipment has developed, and these days the risk of causing an injury to the vessel is really minuscule. The third risk is, of course, introducing an infection inside, because we are going into the body. Again, it's a procedure that's done in a sterile environment, and it's a tiny cut, like an IV line. So again, it's a very minimal risk of introducing an infection. The fourth risk is what Charles has also brought about, the risk of fertility or impact on fertility. So we do counsel our patients that there is a tiny risk of impacting your fertility. It's important to keep in mind that the ovaries predominantly get their own blood supply from their own arteries, but there are some channels that communicate between the uterus and the ovaries. So we can sort of have an impact on fertility or induce premature menopause, but it's a very tiny percentage of patients who would experience that. Yeah.
Okay,
Yeah.
I see
So those are the risks.
Okay, all right. But are there then follow-ups that are needed? And this is, after the procedure, and treatment? Because again, like I said, the recovery period is relatively short as compared to like any other form of treatment. But yeah, are there follow-ups that are needed?
Yeah, follow-ups are required. I think generally after any procedure, you need to see either the surgeon or the interventional radiologist who did the procedures to confirm you're okay.
Yeah.
But for UFE, we usually would see the patient most likely 2 weeks after. From the research we conducted, we actually noted that the symptoms of heavy bleeding almost like significantly reduced within 1 month or two.
Oh, wow.
And if it's a uterus that was big, usually we'd give it around 9 months to a year for it to go back to its normal size. So the symptoms of heavy bleeding are the ones that tend to kind of like get addressed, as soon as possible.
Okay.
Generally, we also just need to do a bit of follow-up in case, there was a fibroid inside the cavity. But sometimes if it dies off, it can cause a bit of, a discharge that can be there. So we always have to follow up on that.
Okay.
But generally speaking, since it's not a surgery, the follow-up is not as complicated.
Okay, I see that. And Rhoda, how are you 11 months later? Just first of all, how soon did you experience the changes, and how did sort of like life shift for you after the procedure, for the better really? Because when you think about the before, it was a little bit heavy. Yeah.
Like I said, after that duration of recovery and all that, for me, the main symptoms went away almost immediately for me, yeah.
Okay.
And in fact, I think just 6 months after the procedure, I opted to do just another MRI just to make sure. Are they dying?
Right. Yeah.
And I even go to a different radiologist or something of there's no conflict of, and they said sure enough they're dead. They're just the few that are there are just remnants that are just waiting to die off.
Yeah.
And to me that was positive. Yeah.
Okay.
So it's for me, I think now it's just a process of just waiting it out, because like Dr. Ari says, the fibroids don't just disappear instantaneously, but at least the symptoms are taken care of.
Yeah.
So we just wait it out, and hopefully, God willing, the outcome much later at the end of the road will be
much better.
Yeah.
Because like you said, you would take a few days off of work to just stay home, take care of yourself, and
Precisely.
then has that changed?
No. Now I'm a fully functioning member,
contributing to the economy.
Yes. Yeah.
Okay. Yeah.
So those breaks that I need to take, just so that, and it's more or less breaks so that you don't embarrass yourself. Those don't worry me anymore. Those are no longer my concerns. Which is
it's a good thing, right?
Which is the main thing. Yeah.
There's a woman who, again, we've had conversations still on fibroids, and they would say, I dread my periods because it's not just painful, but it's heavy. It's like it's a lot of things happening. So I don't know whether that was the case for you before, and how you're feeling now.
That was the case, and I can tell you there's nothing. To the point you even consider wearing an adult diaper. That's how bad it gets. But you try everything, and it's not working. In fact, for me, I think when my first diagnosis came out, what I started now paying attention more to, I'd find people who have lost relatives to fibroids, and it hit me. It's actually serious. It's life-threatening, and actually the death occurs not so much because of the fibroid, but because of the excessive bleeding. So I personally now started being more vigilant with that situation, and I continue to be. Like Dr. Ari said, there's the issue of genetics that plays. I have 2 daughters, so I will also be in my mind be wondering if I have passed on the same problem to my kids. So we remain forever vigilant, but at least we don't have to worry so much anymore.
Right?
Yeah.
So many things that would worry you then are not the same things that would worry you now. All right. And Dr. Karim, are there things that patients can do to support themselves and even just help with the recovery period? Because again, like I said, it's relatively shorter, but are there things that patients can do, either lifestyle, diet, what they do, what they eat, how they sleep, and what, just to help themselves with the recovery period?
So we actually encourage patients to sort of get back to their normal life as much as possible. We do counsel them that they will experience the pain, nausea, and some muscle aches, joint aches. And we do give medication to manage all that. But we try and encourage them to get back to normal as soon as possible. So they can start resuming to walk around immediately from day 1, day 2. And if there are people who go to gym, they can start their gym from week 2.
Oh, that's good. Okay. And also, when you think about just the fibroids, really, in general, one of the things that a lot of women, again, would dread is the recurrence, okay? And I think we've also seen people who, yes, they've gone through treatment with the management, but they still come back. So I wonder whether this should be also a concern for women as far as the treatment in itself.
Yeah, so it's, so arguably the same hormones that make a woman are the same hormones that cause the fibroids to grow. So you can't do away with the recurrence, so to speak, because then you probably would have to subject a woman to menopause. So we know that recurrence happens. Again, it's influenced by genetics. There's some who recurrence might be a bit earlier. Others might take a while before they recur. I joke and say to some extent pregnancy might be protective in terms of reducing the recurrence rate,
and we hear that
but it's not
lot.
But it's not a prescription for prevention of recurrence. You know? So recurrence. That's why we probably say, let's do just a follow-up, maybe once a year, and really just to know how are the symptoms and vis-a-vis how the fibroids looking like, and especially the ones that are symptomatic. We also just want to check and follow up maybe once a year just to see. Unfortunately, in African women, the recurrence is higher than Caucasian. And so we always know that, yes, that's why maybe after a surgery or maybe intervention, then we always have to think that recurrence is something that we have to address. So we will still have the same conversation about what the options would be. Sometimes for my patients who are closer to menopause, I probably say, maybe we could manage it with medication just to buy time for menopause to kick in, because once menopause kicks in, then, the hormones have started dipping, then the heavy flow stops or reduces. And arguably after menopause, the fibroids tend to shrink. I think there was a question like that. So that's not to say that we have to wait till menopause, but that's an option. If a woman is 49, probably no need to do surgery. Maybe you would say, let's try and see if we can buy some time and for you to go into menopause. Hoping that their mother didn't go into menopause at 56.
Because now it's like he's waiting. But at the same time, are there things that probably that women can do to sort of like help prevent the recurrence, either through lifestyle, maybe our diet? Are there things that we can do to just help?
Yeah, I mean, I think I wish there was a magic bullet, but there isn't, because the genetics that make us, African is generally that. And of course, we cannot prescribe, pregnancy, but maybe small things like, keeping healthy, probably reducing weight, that generally would also help your health. But for fibroids, we know that they can recur. It's not to say everyone has definitely recurrence, but it's almost like saying we just need to keep that at the back of our minds. But we should not be scared and afraid that, oh my God, in the next couple of years I'll be back to where I was.
I see that. And Rhoda, do you just speak to the women as well who are watching us and thinking, I have tried everything. even the concoctions that Dr. Charles mentioned earlier, is like we're taking to shrink this thing and just and make sure that it disappears so that I don't have to deal with these symptoms, again. Or someone like, I'm scared. I'm scared to go to a hospital and being told that you have fibroids. Or others who don't necessarily even understand what we're talking about today. They're like, I just don't know. What would you say to them? And especially when it comes to advocating for yourself, but also do your proper research, but also just understand fibroids and the risks that are there, and maybe if you are within the risk factor.
I think now with my journey, I'd say don't be scared. Don't be scared to find out. Yeah. It's better to know than not to know. Because the ones who find themselves in dire situations is because they did not know, and they're finding out towards, more like, so you're being more reactive to finding out last minute. So I'd say don't be scared, just find out. Yeah. And then, like Dr. Ari said, they fibers just kind of play around in your body, sometimes shrinking. As I was having my kids, I guess I did not have to worry too much about it. So I guess they would play around, shrink, and then once in a while now you monitor to see whether and you cannot be able to monitor if in the first place you didn't know you had fibroids. Yeah. So you just monitor this, whether they're increasing in size. You also monitor your own body to see whether now the symptoms are presenting themselves. There's the famous one of you might have, everything else might be fine, but there's not the story of the bulge, because sometimes there are those who are completely okay, but they have this bulge, and clearly they are carrying a fibroid. So monitoring is important, and then when you begin to feel like, and you're monitoring this through the intervention of a doctor, because we don't check into a radiographer's room and say, I want an ultrasound or I want an MRI. That usually is from a request from the doctor. So just monitor, and when you begin to present the symptoms, just now look into ways to manage before it gets too severe, or even worse, becomes fatal.
Right? And thanks for that. Before we talk about then this month and why it's important, because again, like I said, we talked about fibroids for a very long time. So how different should we think about fibroids, and especially during this month? What sort of conversations do we need to have as far as fibroids are concerned? And this is from, the general population audience, but also from a medical perspective, because we talked about diagnosis as well. But let's go through a bit of questions, and then we'll come back and probably wrap up the conversation with that. But the question that we're asking you this morning is, if your body could talk to you, what message would it send? And for those people who are saying, I am my body and my body is me, so what would you ask? Or what message would you send yourself? But yes, the question is, if your body could talk to you, what message would it if your body could send you one message today, what do you think it would say? All right, so let's see, we have a bit of questions on WhatsApp. All right, so this one says, hello, please, I need help from the doctors. I miscarried after a month. I did not see my period, but now I have been in a painful menstruation or bleeding for a month now. What should I do? And then says, painful period under my lower abdomen and through and through my waist for a month now after miscarriage and taking a month without bleeding. Says I need help. I think Dr. Charles, this is more of a question for you. And then this one says, good morning. I was diagnosed with one fibroid, which is 2.14 centimeters. Is there anything I can do to stop it from growing and to disappear? I think this is a question for you, Dr. Karim. But yes, go ahead, Dr. Charles.
Yeah, sorry to that young lady who's suffering. I think the fact that she had a pregnancy and she lost her pregnancy might be one of the reasons why she's still bleeding. So I think it's important for her to see a gynecologist so that they can be able to at least maybe have a blood test and an ultrasound just to see how the uterus looks like and if there's anything of concern, just to highlight that not all bleeding is due to fibroids. I think I would want to emphasize that just because we've talked about bleeding in fibroids doesn't mean that all bleeding.
Yes.
Yeah, it actually maybe in her case it's a miscarriage.
Okay, I see that. Yes, and then Dr. Karim.
Yeah. So for that lady who has a 2.1 centimeter fibroid, unfortunately, like Dr. Charles said, the hormones that make fibroids grow are the hormones that are part of a woman's.
Being a woman in itself is.
So there's nothing much you can do to prevent the growth.
Yeah. Okay. So then, do they need to probably come to a hospital for like an early intervention? Is that an option as well for them?
So they would. It would be wise to be on a follow-up.
Okay.
And to a point where the fibroids become symptomatic, at which point an intervention can be carried out.
Okay, all right. And Rhoda, just coming back to you in terms of understanding, first of all, this month on Fibroid Awareness Month, what exactly does it mean to you as an individual, as someone who went through this journey? And also, number two, what sort of conversations then do we need to start having or stop having altogether from where you sit and having gone through this experience?
Okay, I think it's just unfortunate that not too much attention has. Okay, we are trying to look at ways to manage fibroids, but not too much research and effort has been put into. Like you see, the lady who's talking of having just one is 2.14 centimeters. Yeah. And personally, I'd have those conversations. How do I stop them from growing? Right? I mean, what's the research out there? Yeah. To the point, I think I'd hear you need more vitamin D, so I'd find myself basking out there like a lizard just so that I can absorb all the all the sunlight.
About that as well.
Precisely, yeah.
And we're told supplements. Make sure that you take vitamin D supplements and
precisely,
whatnot. Yeah,
precisely. Yeah. So it's. I think it's during this month. I think people need to advocate for more research. I guess it involves costs in the medical fraternity to put in more research on just finding out ways to curb the situation. Because then again, it just feels like there's this sentence that has been put upon women for being women. But it honestly, more attention needs to be put in, not just for us, but also for the young ladies who are coming up. It's my hope that probably in a few years' time we'll be having more tangible evidence on what a lady should do to be able to manage the situation. Yeah. Or to even reduce. When they say reduce, then we should be able to see that she, without necessarily having to become pregnant. So I think that's this month. I think those conversations should be had. We obviously look out to our doctors to help us make those decisions. And we obviously don't want to rely a lot on what is on social media, because sometimes we can also go overboard with trying to look for remedies. But I think that this month, that should be the month where we take in concerns from women and just look at how we can manage the situation.
I see. And Dr. Charles as well, from a gynecologist's perspective, in terms of this whole month and what it means and what conversations should be had, what misconceptions should be debunked, just to really help as many women out there who are dealing with fibroids and not know what to do, where to go, who to talk to. What are some of these conversations that need to be had?
Yes, I think just having, I now see things differently, especially because of endometriosis and adenomyosis. I think these conversations should happen when a young girl starts seeing her periods. Because that's where the myths tend to be propagated. Your mother had pain, even you should just, stomach it. For fibroids, it's usually, you need to get children as early as possible to prevent them from coming.
Yeah.
And I think these myths need to be debunked. And probably the best way is to have a consultation with a gynecologist regarding that. One other thing that probably I should point out that really helps is, nowadays there are groups that people have come in, almost like awareness groups.
Okay.
I know there's one for endometriosis. I think I've probably seen one or two for fibroid.
Yeah.
It's almost like an awareness group. It's also it's also very positive when prominent people in society, like Lupita, would come out and say, I have had fibroids. It actually validates the women who have gone through this and say, I'm not alone.
Yeah.
And I don't have to be afraid if somebody has gone through this and they've been successful in
Yeah,
life.
because sometimes it can be a very lonely journey.
It can be.
Yeah.
And just knowing that, okay, I'm not alone. There are other women who are going through this and they probably have, one or two ideas of what, might benefit, them.
Yeah.
I think it's important just to have the conversations, even in those groups. They don't necessarily have to have the doctor present. And some of them are actually good because they're informal. They're questions that you may want to ask Rhoda without us being present.
Yes.
And that conversation can happen outside the consultation of the doctor.
I see. And even just in regards to fibroids in general, there's this thing where we always say, and even when you Google, Rhoda said she did a massive amount of Googling and reading, is they say there's no known cause for fibroids, but there could be, and then they list all those things. So from all those things that has been listed, what then should women just think about, be cautious about, and just pay attention to, so that we don't end up in a situation where you go to a hospital and they're told, you have fibroids and it's like almost 10 centimeters, and whatnot. Yeah, from what is out there as far as either research or just what has been published as well.
Yeah, unfortunately for fibroids, the risk factors are some that are not modifiable. I mean, the fact that you have black skin, that you can't change.
Right?
That you can't change. If your genetics put you at risk of fibroids, then that's something that might not be. But some of these small things that might be modifiable, something to do with maybe, let's say, weight, because obesity has been shown to increase the chances of having fibroids or symptomatic fibroids for that matter. Diet, I mean, there's hardly much that you can do in terms of reducing the risk of fibroids. But I always look at it and say, it's also good to just live within the context of these factors don't always apply 100%. Okay? Because it can almost, make it very fearful for a woman to imagine, what must I do? What must I not do?
Yeah. Or some actually say, I must have done something to get myself here.
Yes. Yeah. And that's not true. Sometimes I think if we compare with our grandmothers, they probably didn't have much of this because, if they got married off at, say, age 16 and they had 12 kids, so they're probably pregnant or breastfeeding. That comes to almost 24 years. For 24 years, they've not seen their periods.
Yeah.
They don't know what heavy flow is.
Yeah.
By the time they get to 40, they don't have pain, they don't have heavy flow. So they might not understand when somebody who is 38 and has no children yet and is saying they're having painful periods, they don't understand that. But yet they wish that your quality of life was theirs because then they had to raise 12 children by themselves.
Yeah.
So I think that comparison, we're at a different generation. And I think just because of the choices that we have made in society, which are part and parcel of just progress, might make women be at more risk of issues like fibroids or pain.
I see. I don't know whether we answered this question, but this one says, I was diagnosed with fibroids and I was given treatment, and by the next scan it had reduced in size and I'm in menopause. Is it true that it will disappear with time since I did not receive any periods anymore?
So menopause, because the system is almost slowing down, there's no hormone that's triggering the growth. So they tend to reduce in size. Maybe not completely disappear, but as we said, it's not so much about the fibroid itself is whether the symptoms are there.
Okay.
I'm just curious because usually when we also get to menopause, we are now working towards hormone replacement therapy.
Yes.
I suspected you might ask me.
Yeah,
Yes.
so now does that mean at the time we are engaging in, we will have a
A
recurrent...
crop of
Yeah.
So the hormones that cause the fibroids to go are usually endogenous, meaning they're from the ovaries. But the hormones that we usually give for hormone replacement are actually from outside. So you're managing symptoms like hot flashes, insomnia,
Okay.
vaginal dryness and things. Actually, that's a whole topic altogether. I think
Yes.
we should have a
We've
conversation.
actually
But
had
I think that
three
that has
episodes
been
of series,
ignored
yes.
in our setting
Yeah.
because women are told, "Kishamaliza kupata watoto, bas."
Yeah, that's it.
But yeah, now-
Anything to number because of freedom, you know?
But menopause is something else, and
Yeah.
it's something else.
Yeah.
Yeah, but generally we also have to still risk stratify because hormone replacement therapy potentially also. We need to have a conversation around issues like breast cancer,
I
risk
see.
of breast cancer.
All right. And then as we wind up, Dr. Karim as well, in terms of now the entire month and from the medical perspective in terms of what do we need to change so that we avoid cases of misdiagnosis, late diagnosis. Someone has gone through 17 surgeries only to be told, oh, actually, you didn't need all those. You just needed, if for example, what do you think needs to be done as soon as now? And also probably speak a little bit on cost. I know most specialists do not want to talk about cost, but just to give a range so that people know what to work with. Yeah.
So I think in terms of what needs to be done for the Fibroid Awareness Month is, and basically generally what really needs to be done is patient education.
Yes.
And like Dr. Charles said, I think the education should start when a girl hits puberty about all the facts about what to expect and what's abnormal.
Yeah.
So I think education is the biggest factor that can improve health-seeking behavior. In terms of costs, so at Aga Khan, we offer uterine fibroid embolization as a package.
Okay.
And the package includes everything, including one-night stay, the anesthesia, the procedure, the medication. And that is at around 470,000 shillings. Unfortunately, SHA at Aga Khan is not covering the procedures. So, yeah.
Okay.
But all the insurance companies do
okay.
cover it.
It's
so,
covered.
yeah.
Okay, I think that's a relief, for patients. But unfortunately, that is where we have to say thank you. or put a pin on it. We pause for the conversation because I want to believe this is not the first and the last time we'll be talking about, uterine fibroid embolization. So thank you so much for coming by today. Really, really appreciate your time and also Rhoda as well for just speaking to us about your experience and where you are at now. And we wish you all the very best. Even as you say, we wait it out. We wish you all the very best. And Dr. Charles as well. Thank you. Thank you so much for coming by today. Well, allow us to say goodbye. What a show it has been. And if you missed out probably on the first part of the conversation, this will be uploaded on YouTube by the end of the day. And that is on our YouTube channel, NTV Kenya. So please be on the lookout for that. And thank you for your feedback as well. Thank you for speaking to us. If you have more questions, send them our way and then we'll forward it to our panelists. But for now, we say have yourselves a lovely day ahead. We'll see you tomorrow on Trendy Thursday.